And that's all the debris removed from both ears. So you can see it's quite a big hole there. The surface of this wax and keratin, I should say, there's a lot of keratin there. It's very abrasive, it's very rough. It's almost like sandpaper. So for that reason, it's very difficult to remove because the patient can feel it against the canal wall, and it can sometimes be a bit uncomfortable. Therefore, with this particular patient, we always recommend them to use some drops prior to attending, just to see if we can soften the surface. But despite the patient using drops for a few days, the surface is very, very rough still. And in addition, once I remove this large plug, the patient has very sharp and very uncomfortable for him shards of dead skin. It's almost like glass in the ear. And you'll watch me not only remove this very hardened keratin and wax, but also the shards of dead skin, including on the eardrum as well. Now, you can see the oil in there, and it has lubricated it slightly, but when you've got wax and keratin this hard, it's sometimes very difficult to get a suction grip. And the slight problem is that you can push this further in because you're not getting a grip with the suction probe. You're going to really hover it over the surface, and if you put too much pressure against it, you're just going to be pushing this plug further in and impact it against the eardrum. And the patient was quite astonished at the end of the procedure. They actually got some of this plugs of wax and skin and rubbed it between the fingers, and they saw how hard it was. Now, this is a very good case for me to do the WAXscope because it's one of the more complex ones. And typically I don't recommend my clients having to use a drop prior to attending, but I've probably got one in 100, for example, of clients that I do recommend to use drops because I know it's going to benefit the procedure, and without using drops it's going to be very difficult. So it's a real good test of the WAXscope, this was. Now, if anyone, more so people who never used an ENT microscope, or members of the public who, so viewers, subscribers who don't perform earwax removal, and if they're interested to know what an ENT microscope looks like, this is a very good example of what the ear looks like when they can examine through an ENT microscope. In fact, I've got an ENT microscope, and I'm very pleased with the WAXscope in terms of its optics. For earwax removal, I would put it on par with an ENT microscope in that respect. So we just used an ear hook there, just to chisel this wax and bring it forwards. And I'm using a 4.25mm speculum here. And we've got 4 sizes in total. We've got a smaller one, which is a 3.5mm speculum. We've got a larger one, which is a 5mm, and an extra large one, which is a 5.75. That's more for mastoid cavities. So, you see, bring this slowly outwards. Just looking at some debris near the entrance. And this patient's entrance of the ear canal is slightly narrowed. And if you're using an endoscope, you'll need to use the endoscope to stretch the ear. So you can see here we're just dilating the ear, and I'm just getting this dry wax keratin focus, and it's actually some of it's on the patient's eardrum. So we'll just stretch the ear open, just dilate it with the speculum. I've just got that piece of keratin on the eardrum in focus. I'm now using a fine end suction probe. We're just entering the ear, you can see we're just hovering over it. It actually removes some other keratin that was not actually in view, this suction probe there. So I'm going to go back in. And put it in focus. And slowly going to just peel that away. And you'll see all these little shards of skin was quite uncomfortable for the patient, and as soon as we removed it, they felt a lot better than any itchiness in the ear. So this is on the anterior canal wall, quite medial near the eardrum. So I did spend a bit of time with the fine end just vacuuming this loose debris. So again, this is all dead skin, and in this particular patient, the skin as it dies, it's not really shedding, and it's crystallising in the ear. And that piece there is a good example. It's like a shard of glass. So every time the patient puts in the jaw, it's very uncomfortable. This is a bit of a tricky bit to remove. It was still attached to the canal wall. It wasn't loose, and I had to really peel it. It took me several attempts, or a couple of attempts, I would say. So again, just got the fine end, just got it in focus. You can see that where it's adhered. The patient did slightly find this uncomfortable. So you've got a fresher layer of skin that's still attached to this. But in the end, we did manage to remove. Tear it away, break it up. Okay, it's just dilated the ear with the little speculum. You can see at the top we've got a slit there, and that slit, it enables us to, it gives us more range of motion with an instrument, and also because that slit we can insert the instrument at a high angle, which therefore doesn't obstruct the line of view of the lens of the camera on the WAXscope, so it doesn't become blurry, so we can really see the precision what we're doing. This is some dry skin on the back part of the ear canal, again quite medial. I'm just hovering over. So all this is very deep against the eardrum, the latter third of the ear canal. You can see the eardrum already, it looks nice and healthy, got a lovely view there, very magnified. Still not going to just peel away. And then just adjust the focus a minute just to get this a bit more clearer. There we are. The WAXscope, if you are a clinical ear care specialist, it's due to be launched in early autumn, so if you are interested, do please email info@clearwax.co.uk. And of course, we're still manufacturing our flagship product, the iClearScope endoscope. If you're watching on social media, and if you want to be watching the iClearScope in action, just visit my YouTube channel, just type in the Ear Clinic. And conversely, if you want to watch some more YouTube videos on using the WAXscope, please just when you enter, log in into YouTube, just search ClearWax, and you should go to our ClearWax channel. And I'm using the ClearWax YouTube channel to advertise our the WAXscope. Of course, if you're on Facebook as well, you can, on my Hair Clinic page and ClearWax page, you'll see videos of both the WAXscope and the iClearScope. So this is some dry skin just at the base of the ear canal that we're removing, so it's the inferior aspect, and it's probably more mid-canal. I'm just going to get a view. This is best bit, but it's well worth removing. You may have seen there, just as I entered the ear, just on the outside, the patient had been scratching the ear because of the itchiness caused by all its dead skin. Okay, just having a nice view for the patient's eardrum. So that's the hammer bone, and so you can see into the capillaries. Stunning view there. So this is the patient's left ear, and again, it's keratin and crystallized. This is probably more stone-like, but it's even more hardened than the right ear. You can just see that colour. And that's all built up in 9 months. We see this patient every 9 months. And this one is much more adhered. The patient felt this ear was more comfortable as well. You can see this plug is expanded, and it's now compressing against the canal wall, so there's no open seal there, there's no opening, widening. The patient's just got this heart, almost like a stone in the ear, and the stone's getting bigger and bigger, and it's compressing against the canal wall, and it's creating a complete seal. So once more, just using the speculum just to dilate the ear canal. Just having a bit nosy around. And again, I've just got into the hook, and you can see the angle I went there, I just glided it into the slit, and then once through the slit, I rotate it counterclockwise, anti-clockwise, glide it. In this instance, I went to the roof of the ear canal. You might have just seen there when I pulled pull the hook through that, there was a bit of a juggernaut action there. So it broke some of the seal created by this keratin, and a piece of keratin came out, but it's still quite lodged. And again, inserted the hook, slided it in, and it's just so hard. I couldn't embed it, so I'm just trying to get in and behind now. This is the gap opening at the top now. Dig it in and come forwards. We're just going to be careful when we come forward with this hook. We don't want to lose control over the hook and accidentally injure the patient taking over the tip of the hook, which can easily happen if we're not careful. So we're going to ensure, especially in cases like this when this wax and keratin is extremely hard and it requires a lot of force, that you're just very careful. All of this, now bringing it forwards. The edges are quite narrow. But slowly but surely we are bringing this forwards. Again, I'm just using the speculum just to straighten the ear here, just to widen the entrance. Back at the hook, just want to really widen the ear. I want to go to the back part of the ear canal here. Just take this away from the back part, it's really impacted there. So I'm just chiseling the right back, just loosening it out. Then over the roof. And although the plug hasn't come out, I have chiselled it into little pieces. So yeah, I'm going to go back in with a suction probe in a minute, just to suction up all the debris, loose debris that's in the concha bowl. And sometimes with a hook, you're using it in combination with instruments. And not necessarily always extracting the wax, you're just chiseling into little pieces to remove the rest of the wax. Now, in this kind of case, you couldn't just remove this just solely using microsuction. That's why, as a clinical ear care specialist, you need to be competent in all instruments, not just the suction probe. I'm aware that some people are just using suction and they're not really comfortable or not able to have been trained using any instruments. And it's very important that if you are a clinical ear care specialist, you need to be able to remove wax, not solely reliant upon microsuction. It's just a case like this is a perfect example. You wouldn't have been able just to remove this just by using microsuction. You have to get the patient back after a few days of using drops and potentially again several times. And sometimes it doesn't really soften this kind of keratin. You're going to be struggling and having to just refer the patient onwards. So when we're developing the WAXscope, it was developed in such a way whereby we're optimising the use of instruments as well, all instruments, not just microsuction. So I'm just trying to go to the back part of the ear canal. This is where the speculum does help. You can see I've just separated that. There's no space at the top, but I'm just to move this so it gets over and behind. I think now I'm going to just revert back to the suction probe, as you'll see. Just like the patient's right here, so it comes quite narrow. And it's just going to be once more a bit trepidous here, because you don't want to be pushing this keratin plug further in. Looking for the suction grip and just removing some keratin from the top part of the plug. Just straightening and stretching this a bit more with the spatula. And I've just found a spot here where I can position the suction probe, and I'm just slowly teasing this forward now. I think it just gets trapped. So I brought it forward, but it gets trapped at the ear canal entrance. But I have mobilised it, and I think again I'm going to potentially use a hook just to extract this from the roof. And I'm going to go over and beyond. And I'm going to glide the hook in behind, which I have now. That's the main occlusion removed from the left. So we're just going to mop up some dead skin. This is just very lateral on the anterior canal wall. We're going to peel this away using the fine end, and in fact a large piece of skin has actually come away. You see it's getting all the way to the eardrum there. Like the rest, that was in the patient's right ear, that piece of skin was very hard and crystallised. So I'm just going to change the focus just to visualise the patient's eardrum. Again, you can see all the capillaries there. Fantastic magnified clear view. And with this particular patient, so I'm going to try and remove as much debris as possible. You can see this crusted layer of dead skin at the base of the ear canal, so I'm going to peel this away now using the fine end. Just getting it in focus. I've got some arthritis externa, some eczema psoriasis of the ear canal. They have got some prescribed antibiotic spray from the GP, which they're going to use now once we've removed all this. So just using the fine end, just going. It's very strongly adhered, so I'm just trying to get the fine end and tussle this away from the back part and separate this. Now, removing this is not going to improve the patient's hearing, but the skin's not going to come out by itself, unfortunately. It's dead, it's just attached itself to the canal wall, so I'm going to just remove it for that reason. And this can cause a bit of itchiness in the patient's ear as well, just kind of really across the skin. Just using the fine, just trying to get in and behind skin and curl it, and curl it, peel it away. It's been removed. That's the patient's eardrum, again nice and healthy. And that's all the debris that we removed from both ears, so you can see it's quite a big hole there. And I hope you enjoyed that video, guys, and if you are interested in the WAXscope, please do email info@WAXscope.co.uk. Thank you, bye.